The following content is for informational purposes only and should not be considered medical advice.
Welcome to KC Wellness Talks. I'm Dr. Dawn Ipsen, pharmacist and your host. Join us as we delve into the world of healthcare with local providers discussing common health concerns many face and explore ways to overcome them. Whether it's from simple home remedies or the latest in treatments and technologies, we've got you covered. Today, I'm excited to introduce to you our guest, Dr. Jon Berner. Thank you for being here today.
My pleasure.
Wonderful. Let me tell you a little bit about Dr. Berner. Dr. Berner is a board-certified psychiatrist in solo practice since 1997 at the Woodinville Psychiatric. He has a highly accomplished background, which I cheated and looked further beyond your bio, just so you know, of education and training from Harvard, UCLA, and the University of Washington, holding both PhDs and an MD. He treats brain disorders broadly defined in all age groups. He typically sees patients with difficult bipolar and psychotic illnesses, complex pain, addiction, and undiagnosed neuropsychiatric syndromes. His practice also includes less complicated general psychiatric, including anxiety and depression. Dr. Berner is committed to promoting new scientific developments. He has published multiple papers on new treatments, and he's an active member of the Biologic Psychiatric Society, the American Academy of Pain Management, and the Washington Academy of Pain Management. And he teaches students frequently in his office setting. We were just giggling too because we were talking about when you're not working, which doesn't happen frequent.
No.
You love, or maybe not love, but you do.
I love it.
You
do.
You love taking direction from your wife. You have 3 children, 4 horses, and a dog.
6 horses now.
We're up to 6.
We're up to 6.
Yes,
Yep.
and we were just enjoying a brief conversation about horse riding. And what was your quote on that?
On horse riding?
Yeah.
Well, my wife's an endurance rider,
Yeah.
and nothing is significant to them. If you have a tough ride, it's like, yeah, but did you die? That's all they care about because they do 100 miles all the time.
Right. And did you
in
die?
24 hours?
Yeah.
Well, it was hard. Well, that's fine. Did you die?
Yeah.
Whatever.
You lived. Yeah.
Right.
She's a very tough woman with
Very.
lots of dedication.
Very.
And
Yep.
in great shape.
Yes.
Yes, very much so. So, you and I have known each other quite a long time.
Yes.
We've done a few things here and there.
Yes, we have.
Especially through the Washington Pain Academy, which
Yes.
is a lot of fun. But what's really interesting is Dr. Berner, I always have the greatest conversations with you because you understand research and the backgrounds in that and really look at things from a different light, which I think is important to share with our audience. And specifically, we talk a lot about different conditions of the brain, but it all comes back to brain inflammation. And how did you get interested in the area of brain inflammation specifically?
I think to answer that question, I want to define the term inflammation.
I think that would be a great place to start.
So, my good friend says that in clinical practice, there's a lot of wizard words that you use to show off your learning. Things like mitochondria,
Oh, yes.
and inflammation,
Oh,
right?
yes.
And they seem so powerful, but
A little buzzy though, right?
well, right. But
Yeah.
your knowledge is a mile wide and an inch deep, right? And so if you look on the Mayo Clinic website, they define inflammation as the body's ability to fight off viruses and bacteria and fungi,
Okay.
right? External threats.
Right.
Right. And I think it's a lot deeper than that. Inflammation is also wound healing, right? So the immune system, the specialized cells in the body, the white blood cells, they're not just monitoring for foreign things, they're monitoring for age and decay and overuse. And, inflammation is a good thing, right? It's not a bad thing.
Right. It's part of normal life.
We can't survive without inflammation.
Right.
Right. So, so brain inflammation is occurring every night. I mean, there's a fire in your head while you're sleeping when the little white blood cells in your head are digesting the wear and tear of the day. They're editing your memories and they're pruning the branches of your nerve cells in response to inflammatory signals.
Very good.
Right.
Okay.
So, you know, to say that you're interested in brain inflammation is to say that you're interested in, you know, essentially how cells in the brain talk to each other, because the language that they use is more than just neurotransmitters, dopamine and norepinephrine, which is, you know, what's going on in the last 10 milliseconds or last 100 milliseconds. But they're also monitoring the cytokine environment, things like tumor necrosis factor alpha and IL-4, you know, interferon 1. You know, they have to have a feeling for how old and tired is the cell next to me.
Okay.
And what am I going to do about it?
All right.
Because cells are always talking to each other.
Right.
In a local environment.
And it becomes part of that cell cycle too, of the cell regeneration and death and continuing on.
Right.
Yeah.
Fantastic. It's a beautiful point, right? Nerve cells, the number of nerve cells you have in general is what you're born with, right? But every other cell in the brain has a turnover time.
Right.
You know, 4 to 10 days. And there's a constant cycle of birth and renewal and death within the brain with these cells. And of course, the deep question is like, well, how do these cells know when to die?
Right.
And how do these cells know when to be born? And, you know, what determines when a white blood cell in the brain, the microglia, is old, right? And it needs to die and have another one take its place. We don't know anything about this stuff. I mean, if you're a hematologist, you stick a needle in the bone marrow and you can do bone marrow biopsies. But we have our own bone marrow in our brain, which is the microglia, and these white blood cells self-renew.
Right.
Right. They migrate from the placenta when you're 4 weeks old in the embryo, and then they renew for the rest of your life. And we know nothing about that bone marrow.
We still have so much to
Nothing.
uncover. We're barely touching the crust of the top.
We can't do brain biopsies in these folks, and so we're just guessing about what the conversations are going on.
Very true. Well, where did your interest come in this area? How did you get in this?
Well, I first started prescribing ketamine in 2007.
Okay.
Okay, and so it's been a wacky ride for the last 17 years.
Right.
Trying to understand, you know, what is the right patient and what is the right dose. And there hasn't been a lot of guidance from the academic community.
Right.
Because the academic community, to some degree, has been entranced with pretty pictures.
Okay.
You know, they love brain imaging.
Yes.
And they love EEGs.
Yeah.
And they love checklists of symptoms.
Okay.
But that's not really biology, right? That's just pretty pictures, right? And so they're lost.
Okay.
Right? If you look at the vast majority of ketamine research, it's not really related to the diversity of human biochemistry. You know, because we're all dealt a different deck of cards when we're born.
Right, for sure.
Right, and not all of them are abnormal cards. I mean, the vast majority of us don't have a 16 of clubs, right, or 5 jokers in the deck.
Right.
Right, we just have an imbalanced hand.
Right, you have the genetics, you have your background from that.
Right, but it's
Then
imbalanced. There's nothing wrong with it. It's just not balanced.
It's normal.
Right, it's normal, right? But that imbalance can set you up for different susceptibilities to different diseases.
Okay.
And so it became clear from the beginning that ketamine's target was probably the white blood cells in the brain, the microglia, which are responsible for repair.
Right. And aren't the microglia also tagged as being connected to, say, autoimmune disorders and things of that nature as well, where they impact the repair and the recovery in the sense of that as well?
Yeah, I think so.
Yeah. I think I remember hearing about that. Or,
well,
you know,
I mean, I don't know how much we want to get into it, but I mean, the concept in the bone marrow is that there are 2 different subtypes of white blood cells in the bone marrow. The old subtype is the myeloid lineage.
Okay.
Okay, and these are white blood cells like macrophages and neutrophils and eosinophils and mast cells and basophils.
Right.
And these cells are ancient, right? And when they get information from the environment, it's a very general information, like, oh, that looks like a fragment of a bacterial cell wall, or that's a piece of DNA, or that's a piece of RNA, or that's a flagellum in a bacteria. They don't have any specific way to sense the environment.
Okay.
When the bony fishes hit, we developed specific receptors for very specific protein folding, things like antibodies and T cell receptors.
Okay. Yeah.
And those are the lymphocytes.
Okay.
Right. And so they're new, right? And most autoimmune disorders are, to some degree, proximately driven by the lymphocytes, because you see tissue destruction.
Right.
Right. You see a hole in the colon, ulcerative colitis, or you see damage to the joint with arthritis, right?
Antibodies,
or you see
for
destruction
thyroid.
of the thyroid, right?
Yep.
And these, to some degree, are proximally driven by cell death, driven by antibodies and T cell, cytotoxic T cells, right? And what confuses people, I think, is that there are plenty of people that don't have a lot of lymphocyte involvement, and there's no cell death, right? But the myeloid compartment, the ancient compartment, is hyperactive.
Yes.
And patients are inflamed, right? And so they go to their physician, and the physician does scans and does exams, and they say, hey, I don't see any cell death.
Right.
There's nothing wrong with you.
Right.
Or it's in your head.
Right.
Right.
Unexplained, essentially.
It's unexplained.
Yeah.
But you know, it's obvious. It's obvious, right? I mean, this is first year medical school. What is inflammation? You know, we learn this like the first day, right? Which is swelling and redness and pain that is part of the initial inflammatory response. But it's not driven by a specific signal. It's not COVID, right?
Not a
it's
cause.
not Lyme's disease. It's not a
Right.
specific antigen.
Right.
These are non-specific antigens.
Yeah.
Okay. Very much what you see with something like even the mRNA vaccines, you know, for COVID, right?
Yeah.
Right. The reason people got sick after these vaccines was not due to the specific sequence in the mRNA vaccine. It was due to the presence of RNA itself,
Right.
which is an activator of the innate immune system, and
Kicked it on fire.
and started it going.
Yep.
Right. RNA
People felt it.
alone is an activator of the immune system.
Right.
Right.
Yeah, for sure.
Right. And that's the distinction, I think, is that one of these great unknown territories is how do we evaluate the function of the innate immune system, our oldest immune system, in the brain, when we don't have any way of actually evaluating the little tiny signals that are going on between the cells in the absence of cell death.
Right.
And this is it's a difficult technical problem.
Yeah.
And
With probably no answer in the near future anyway, do you believe? Of how we're going to get there?
I'm doing it now. It's fun.
Oh, you are?
Oh, we are.
Okay.
Then
let's talk.
We have a paper under review. It's really
Great.
Where we took blood cells from 30 patients.
Okay.
And
Just a standard blood draw?
Just a standard blood draw. Okay. And we sent them off to Columbia.
Okay.
And
Columbia University, I assume.
Yeah, Columbia. And what they did is they took these blood cells, and we looked at how much of a simple protein, S6 kinase, which is a marker of protein expression. In other words, if a cell is growing really fast, it's going to have an elevated amount of S6 kinase so that it can convert RNA into protein. And we looked at this, and we correlated this with sorts of symptoms that people had, and it was obvious that just by looking at people's growth characteristics of the white blood cells in the bone marrow, we could make some inferences about who was going to respond to ketamine and who wasn't.
Really?
Because the white blood cells in the bone marrow are not exactly the same as the brain, but they're closely related, and they share a lot of the underlying chemistry.
And that would be a much easier test to take from a patient than, going.
Yeah.
Right. It's,
We
you
don't
do
need
it all the
an
time.
It's $45, right? You can get
Isn't that amazing?
You can get a blood draw for $45
Yeah.
at any lab, right?
Right. So
Now, I mean, we haven't published this, but
Sure.
other people have looked at this sort of technology
Yeah.
in COPD.
Okay.
They've
Okay.
looked at this sort of technology in asthma that responds to steroids and doesn't respond to steroids.
Okay.
All of these papers have come out in the last couple of years.
Okay.
I mean, they're really new, and there's no commercial technology yet,
Okay.
but it wasn't complicated. I don't have any money, right? I
Yeah.
have no money, right? And if I can do it with just a little clinic in Woodinville, there's no question that once, the big boys and girls get involved, that we should be able to do this without a lot of work. And other people will come up with good ideas. It's just we need time to come up with cost-effective ways to do this. I mean, these
Right.
$4,000 MRIs are just, not going to be helpful.
Right. They don't
Right.
give the bottom line information we really need anyway.
They don't give the bottom line
Okay.
information. And
Yeah.
more importantly, the vast majority of cells in the blood are stem cells, right? They're not
Right.
doing anything. They're being
Yeah.
transported from their birthplace, almost like a butterfly in a chrysalis, to the tissue. And so it's not until they are in the tissue that they see the signals that tell them to develop into who they're going to be. And this is well known in the problem, right?
Yeah.
Looking at blood to some degree is like the drunk under the light post. You're looking at stem cells. You're not looking at
Right.
differentiated cells.
Right. Okay. So the pre, essentially, the before we even know yet where we're headed.
Right,
Yeah.
right. You go to your rheumatologist, they do a blood draw, they say, well, there's nothing funny in my blood. And you say, well, I'm not worried about my blood.
Right.
I'm worried about, well, my brain is inflamed, or
Right.
well, I have a skin disorder.
Yeah.
The cells don't become abnormal until they're stimulated within the tissue.
In the tissue itself, and
Within
not
the
in
tissue
not
itself.
in the veins,
And not in the blood, right, exactly.
Yes. Okay, that makes a lot of sense. All right, so that's really interesting. So, at this point, early information, but looking really super promising. Gosh, why aren't we doing this more already? Right? I mean, it makes you wonder that
It's new, right? It
just
things
takes a
take
while,
time.
right?
Takes time.
We got to get that paper out there. We got to get others
we-
looking at it and
we-
trying.
Yep.
Yeah, and then we go more.
And we go from there.
Yeah. But with this, so you were mentioning ketamine. So tell me a little bit, or tell our audience, as you and I already know, but what are the types of disease states or processes or symptoms, you might say, that sort of trigger to think about that drug as being a tool?
Good. Okay, so let's talk about the randomized data.
Okay.
Since there's a lot of excitement about this drug, which is wonderful,
Sure.
right?
It is.
But,
Yeah.
it's easy to get over your skis.
Right, absolutely.
Right, so here's the randomized data.
Okay.
Harvard came out with a study, New England Journal of Medicine, 400 people randomized to our oldest treatment, either ECT or intravenous ketamine,
Right,
Okay.
okay. When was that, roughly?
about a year ago.
Okay,
Okay.
pretty
in,
recent.
In that group of people, 55% of people who had already failed antidepressant treatment
Okay.
had a substantial clinical response to ketamine.
Wait, say that again. So if you failed a standard antidepressant,
Multiple standard antidepressants. The
Okay.
inclusion criteria would probably be 2 or 3.
okay, so tried and failed multiple, 55%
55%.
of those would end up having a positive
A
response.
substantial clinical response
Wow, substantial to ketamine treatment.
to ketamine.
Okay.
And that's consistent with, and that was even a low dose. They didn't
Yeah.
titrate the dose aggressively.
Right, okay.
About 2 or 3 years ago, one of my my next door neighbor girl, who is now just graduated from medical school, came back to see me, and she's like, "John, please give me a project because my mom's going to make me weed."
Oh, yes. And no post-grad
Please,
student
I
wants to
just
weed in the summer.
give me something to
Yes,
keep me out of
I'm
my mom's
busy.
clutches.
Yes.
And so I said, "Why don't you go to our local ketamine clinic and do an audit
Ah,
and see what you find?"
yeah.
Right? And she spent a month going through their charts. And she came back, and what she found is that 70% of people that went to the clinic and
Okay.
had 6 infusions
Okay.
wanted to continue,
Okay.
right? And so, we saw this at Harvard, and we see this in our own community.
Yeah.
I mean,
reproducible
There's a
for sure.
reasonable group of people that have depression
Okay.
that don't respond to any antidepressants that will respond to ketamine. Okay, it's a reasonable amount.
Yeah.
Okay, so that's one group that responds.
Okay.
There's the people with chronic pain, right?
Oh,
I mean, these
okay.
are inflamed people. You know,
Right.
referencing our previous discussion.
Yeah. Right.
Right. So in randomized trials that were done, gosh, back in 2003, 2005 with
Wow.
Schwartzman. Okay.
Okay.
They randomized people to very high doses of ketamine, 2 milligrams per kilogram versus 4 milligrams per kilogram.
Okay.
IV
Yeah, those are-
per hour. Those are big
those
doses.
are big doses.
These are big doses,
Yes.
right?
Right.
Okay. And in that study, they had to stop it because it was unethical to give the 2 milligram people that dose. They found out pretty quickly it was ineffective relative to 4 milligrams.
Oh.
So we have
okay.
randomized data
Okay.
in chronic pain syndromes that very
Yeah.
high dose ketamine is effective.
Okay.
And for any of you out there who want a narrative rather than just listening to me talk, I mean, there's the famous Take Care of Maya movie on Netflix. You know, it's a beautiful narrative of how important ketamine can be for people that have life-threatening pain and, you know, when nothing else will work, right? And it clearly is very effective. Again, not for everyone.
Oh,
Right,
absolutely.
right. You
Right.
know, what's the right patient? What's the right
Yes.
dose?
Right.
Right. So it's effective in that group of people.
Okay.
Post-traumatic stress disorder, terrible disease, right? I mean,
Yes.
terrible, terrible, terrible. The
Yes.
Veterans Administration has really had a hard time with this.
Yeah.
Randomized data, 30% improvement in people with PTSD. The Seattle VA now has their own ketamine clinic,
Oh, that's wonderful.
right? So,
Yeah.
you know, it's standard of care at the VA,
Okay.
right?
Because, I mean, generally speaking, in a study, a therapeutic study, when we see 30% or better of positive outcome, that pretty much ties the bow that that's a good therapy to be considered in that specific group.
Well, I think
it's kind of a threshold.
It depends
right?
on disease severity, right? If
Yeah,
you're
that's
on
true.
if you're on oncology and the disease is fatal,
Yeah,
you know,
you'll take a lower number.
no, I mean they'll
Yeah.
take you'll take
Yeah.
a 6-month survival, right?
Yes,
you know,
absolutely,
I mean,
that's
you know, it just
Depends.
It's the risk and cost of the treatment versus the risk and cost of the disease, and
Right.
that's
okay.
always a personal decision that shouldn't be made by government bureaucrats,
True.
right?
Yeah.
That's between you and your doctor, ideally,
Yeah.
right?
Awesome.
So PTSD is probably helpful.
Okay.
After that, there's enough edge cases. I'll leave it for now. There's going to be more.
Okay.
There'll be more, but
Fair
those are the biggies.
The three big ones.
The-
So
yeah.
refractory or resistant depression that's tried and failed other therapies, pain management, chronic pain, primarily
pain,
chronic
right.
pain,
Yeah,
and then PTSD.
PTSD.
Okay.
Yep.
Okay. Great. Okay.
Anyway, so it became clear that ketamine was an anti-inflammatory in those groups, and certainly in the pain patients, right? That
Right.
The target was the white blood cells in the brain, and so then you have to, you know, sort of dial down a little bit. Like, well, there's a receptor that ketamine binds, the
Right.
N-methyl D-aspartate receptor,
Yeah.
and you know, what is it doing on that cell, and you know, how do we know what dose and
Right.
timing and this sort of thing, and no one has the money to do studies in thousands of people. I mean,
Right.
we don't have the time to do these kinds of things.
Because even the
And-
studies you've mentioned are, few hundred.
A few hundred, right?
Yeah.
So, you know, we have to be smart and use science
Yeah.
and just try to understand why it's working. And then when we understand why it's working, we can hopefully, you know, provide more cost-effective care to people, right? Because one of the crises in the ketamine story is that a lot of people can't afford it,
Right.
right? It's, you know, if you have an anesthesiologist do it, you're looking at $2,000 to $4,000 for 6 sessions, and these days Premier is not covering it anymore.
Oh, really?
No,
Really?
no, the Premier stopped covering.
Oh my gosh.
So, you know, the VA uses it as a standard of care, but not commercial insurance,
Really?
right?
That's disheartening.
Yes, it is, right? And
I mean,
then
especially with our, our national mental health crisis that we're really dealing with.
I mean, without pulling
Yeah.
the drama card, I mean, it's a
Right.
crime.
Yeah,
It's a
right.
crime, right? I mean, we have suicide kills
Mm-hmm.
thousands and thousands of people a year,
Mm-hmm.
and the quality of life from depression that is lost is, inconceivable,
Yes. Right.
right? And we have a treatment that has a 55% response rate,
Mm-hmm.
and only rich people can afford it. I mean, it's
Wow.
just it's there's no forgiveness for this,
Wow.
none.
Wow.
And our academic and regulatory authorities don't care.
Wow.
They're not set up in a situation to care,
Wow.
right? And so, part of the trick is going to be, how do we get ketamine to people in a way that is appropriate medical use?
Right.
It's a controlled substance.
Right.
The people are using it appropriately. It's not diverted to the street.
Yes.
That there are not charlatans out there who are taking advantage of desperate people.
Mm-hmm.
And it's not enough for you and I to keep working on this. Right?
It has to be a bigger.
We need
Yeah.
the thought leaders in the area
Mm-hmm.
to just go, I get it. It's not right that this is only available for rich people.
Right.
And just
Yeah.
once you take that as a premise,
Mm-hmm.
everything else will take care of itself. But we haven't
Right.
reached that point yet.
Right.
Yeah.
So it's cost prohibitive, definitely so. But then there's even the barrier of access to care. I mean, the infusion clinics, it requires somebody to be able to drive or get transportation to that facility, and quite a long process of time commitment during the procedure and
Sure.
follow up and
Sure.
all that. So, yeah, complicated, very complicated.
It is. Yeah.
Yeah. So what else? So what are some other thoughts on the brain, on brain inflammation, on ketamine? I mean, we're doing some novel things too.
Well, I think one thing that I'm interested in these days is taking advantage of the intellectual interest in life extension.
Okay.
Okay, so there's a lot of money in this area.
Okay.
So the Saudis have invested a $20 billion hedge fund.
Really?
Yeah, it's called Hevolution,
Really?
right? We're to invest in life extension technologies, and I think people that I don't know who they are, but I suspect they're tech giants, are funding very expensive interventions in lifespan. They're taking a hedge that they're going to live longer,
Okay.
by investing in longevity. And so there's billions of dollars pouring into this. The government's all over it. All of our political leaders are old,
Yeah.
right? And they know what's coming, right?
Yeah. Yeah.
And so there's this sort of agreement, this is worth doing,
Okay.
right? And it's attracting a lot of young people with flexible minds.
Sure.
The
yeah.
technology is really well done, and it's just not the same world that it was 10 years ago, where it was sort of like, I'm going to cut off my head and put it in a freezer,
Yeah.
or I'm going
right.
to download my brain onto the internet,
Yes.
or
or
I mean, like
freeze it
really
in.
crazy stuff.
Yeah.
Like, I'm going to pay people who are young to, and I'm going to take their blood and ingest it in my body, and then put it into my body.
Almost like sci-fi
Oh
movie,
yeah, there was
right?
just this quality of like, I can't listen to this.
Yeah.
It's too crazy.
Yeah.
Right?
Right.
And now I think I can tell the community out there that I'm almost certain we will have cured Alzheimer's in the next 5 or 10 years. I think it's going
Yeah.
to be that fast.
Okay.
And maybe not 10, but soon.
Okay.
And the technological advance, to some degree, and there's multiple technological advances that are sort of interlapping at the same time.
Okay.
Okay. The first technical advance is that we have animals now that we've bred to have Alzheimer's, and we've bred to have Parkinson's disease,
Okay.
and they're really cheap.
So good models.
Good
or
models,
reasonable model.
reasonable models, and they're cheap,
Okay.
right? And they develop these diseases very quickly. Right?
Okay. So we don't have to wait the
We don't have to
decades
wait.
and decades. And,
Okay, and so now this sort of research is no longer the playground of Harvard and MIT, and these rich facilities with very ponderous bureaucracies, Turkey's coming out with papers, and China's coming out with papers, and Iran's coming out with papers.
Wow.
And so
A huge collaboration.
It's huge. There's a worldwide interest in this.
Yeah.
And it's cheap and it's fast, and keeping track of it is going to be half the problem because so many people are doing it.
And probably different variations.
Yes,
and,
exactly.
Trying to get the consistency.
It's not all of the way that federal research is done these ways, it's so terribly inbred.
Yeah.
Right? Your graduate student now gets a position at Cornell who goes to the NIH and gets money to do the same thing that you were doing. And it's terribly dull, and it's just not very innovative. And because the technology is so cheap, we're able to go really quickly.
Okay.
So that's one development that's encouraging.
All right.
And then the other development that's encouraging is just the computerized analysis, right? We're able to look at huge swaths of biology all at once with computers. And Turkey doesn't do that, and Iran doesn't do that, but our big companies are doing it, and it will be a blink of an eye before the private guys take over. And the private guys are going to go 100 times faster than the academic
They're more
guys.
nimble.
They're nimble.
Yeah.
I mean,
And
if they can tap your phone when you're talking to your sister, and next thing you get an ad related to a pool maintenance device, right?
Right.
You don't want to know how fast they're going to solve this.
Yeah.
Once they figure out, that this is a profitable area.
Right.
Right. So, yeah, it's going to happen really fast.
That's incredible. It's actually really inspiring.
Yeah, we're going to solve it.
I mean,
look, we know for a fact, right,
Yeah.
that there are people who make it to 105 and have absolutely no Alzheimer's and absolutely no Parkinson's disease.
Okay.
We know this.
Right.
Right?
Yeah.
It's not inevitable, right?
Right.
And we know that the bowhead whale lives 200 years.
Okay.
We know that.
So how do we duplicate, replicate,
So we need
guide?
to find the pathways
Yes.
that allow our microglia to repair our nerve cells better.
Okay.
Right? It's just, we're kind of circling around here.
Yeah,
right?
we're going, right back where we started.
How do we divert a little bit more energy away from being a genius? And we don't all need to be geniuses.
Yeah.
Right? How do we just get our oil changed every 7,000 miles, right? And rather than every 10, right? Yeah. That's all it takes, from a theoretical perspective.
Right.
And so many people are working on this that I think it's going to be good. Now, the other development that's coming out is we have now a blood test that we can do at LabCorp.
Okay.
Where we can measure how many crystals are coming out of your brain into the blood, which is sort of the process of Alzheimer's and Parkinson's disease.
Wow. Okay.
So, again, the immune system hates crystals.
Right. AKA gout.
Gout.
Ouchy
right?
toes.
Right, but we go back. Go back to what I was talking about, the myeloid compartment, right?
Yeah.
This ancient immune system doesn't recognize COVID, and it doesn't recognize Lyme's disease. It recognizes ancient generalities.
Right.
And one of them is like, what's a crystal doing here? It shouldn't be here.
Right.
I should eat it up and recruit other cells to come in and eat it up.
And have a huge inflammatory response.
Huge inflammatory.
Red and
tell the local tissue to not do anything, right?
Right.
Everybody nearby shut down. We have a
protect yourself.
We have a disaster going on here, right?
Yeah.
And so now you have guarding of the joint and guarding of the limb because it hurts so bad.
Right.
And now you can't do anything for a week because you have a gout flare.
Right.
Okay.
Yeah.
So you can imagine a crystal in a joint, how terrible that is.
Very.
Right?
I've seen those patients come in.
Right.
They can barely walk.
What happens when you have a crystal in your head?
That doesn't sound very comfortable either.
Right, and so you have a tau protein.
Okay.
And there's too much of it being made, and it reaches a concentration, and now you have a crystal. I have a crystal in the nerve cell.
So a tau crystal protein.
Right.
Okay.
That's a Lewy body, right?
Yes.
Okay, or then you have an amyloid protein, and it forms an amyloid plaque.
Yes.
Right? And
so
now
Lewy
that's having an amyloid plaque, right?
Yeah.
And the immune system says, what are you doing here? Let's go nuts and get rid of this thing.
Right.
Right?
Okay.
And so if the immune system is not well modulated, it doesn't clear the crystals, or it has too much of a response. And too much of a response now tells the local nerve cells, that it's the problem and it
Right.
should kill itself.
Right. Okay.
Right? So remember, there's this
Yeah.
conversation in the local environment
Yeah.
that tells the local cell, oh, you're the problem, you need to kill yourself.
You're gone. Yeah.
Right? I mean, so again, 600 million years ago, there was a moment of evolution where we went from monocellular organisms to multicellular organisms.
Mhm.
And part of the way that a multicellular organism survives is the cells kill themselves. They have suicide programs. And
Okay.
that's the only
Yeah.
way
Apoptosis and
that a
all
multicellular organism can survive
okay.
is if old cells die quietly,
Right.
right? And so when the immune system overreacts to a crystal,
Mm-hmm.
it tells the local cells, maybe you're part of the problem
Mm.
and you need to kill yourself,
Oh, okay.
right? And that's part of what happens potentially in the difference between people who are 95 and have crystals in their heads, but they don't have a lot of cognitive impairment,
Yeah.
and the people that are 95 and have crystals in their heads and they can barely take care of themselves and they're in a nursing home. Is it the inflammatory response to the crystal?
Okay.
You know, it's a double hit model.
Right.
You got to have the crystal, but you also have to have an abnormal immune response to the crystal in order to get the full
So
syndrome.
you have to have both.
You have to have both.
In order to have
Right.
the Alzheimer's,
To have the full
the
syndrome.
full spectrum.
The full spectrum.
Okay.
Right.
But you could have crystals only, no inflammation, potentially.
Oh, I mean, this is what
Yeah.
drives neurologists crazy.
Yeah.
Which
yeah.
is they'll do these tests and they'll say, oh, this person has a lot of plaques and tangles,
Yeah.
but doesn't really have that much cognitive
But they're
impairment.
totally pretty well.
Right, and
Okay.
they seem to be doing pretty well. And
Okay.
is the difference the specificity of the immune response? It looks
Okay.
that way. If
It's
you
the
look
immune-
at the genetic risk factors for Alzheimer's,
Yeah.
50% of the genetic risk factors are not in nerve cells, but they're in microglia,
Okay. Yeah.
right?
That makes sense.
So it's a double hit model. And you know, the obvious issue to do, which is obvious, right, is how do we cure gout, right? We lower uric acid levels.
Right. We break up the crystals and get.
We
the
don't get
crystals
crystals,
gone.
right?
Yeah.
If you can get your uric acid levels low enough,
Mhm.
you don't get gout and you don't have to worry about modulating the immune response.
Right.
So, you know, if we can come up with medications that lower the baseline rate of tau and amyloid production, then
Right.
you're not going to get crystals and you don't have to worry about immunomodulation.
Is there anything positive that comes from having tau or amyloid proteins?
Oh, this is fantastic.
I'm just curious.
Yeah, no, these are fantastic, right?
Okay.
So what is tau? Okay, so tau is, well, no, I'm thinking,
I mean, if we can.
tau is I don't want to get into a lot of
Okay.
this because it gets into basic biochemistry very quickly.
Okay.
But you know, we have mechanisms of turning on or off protein production.
Okay.
And we
Right.
have mechanisms of turning on or off mitochondrial production,
Okay.
portions of the cell. And when a cell is sick, it's
Mhm.
going to make more amyloid and it's going to make more tau. And then at a certain point, it makes so much of it, it precipitates within the cell and
I
you
see.
get a crystal.
Okay. So
Right.
having some sort of low healthy level is probably very common and normal, and it becomes a big problem when it's excessive or builds up into
Yes,
crystalline
I
forms.
think that's
an
I
easier
think that's
way.
this is, I'm not certain, but I think this
Yeah.
is where the field is suggesting, right?
Yeah.
Right now, so there's
Okay.
some data now in individual, it's not good data, it's very early,
Okay.
that in people whose brains are not firing at high rates, and the classic would be schizophrenia, right? That you see low levels of tau and amyloid.
Oh,
Okay, because the cells aren't working very hard.
they're not
There's nothing to maintain,
producing
right?
any
This
protein.
is your grandma's car that she just drove on Sunday to church, and you know it's a 1985 car and it's got 30,000 miles on it, and you can't believe you got this smoking hot deal, right?
Right.
Because there's no wear and tear,
Yeah.
right? And so
Okay.
there's almost certainly people that don't abuse their nerve cells by running them at high rates,
Okay.
and so they don't get the wear and tear, that other people do. And we have to move away, obviously, from a metaphor about abusing your nerve cells into what actually are the chemical manifestations of abusing your nerve cells. Right?
Yeah.
Rather than just use hand waving. Remember, because I went back to wizard words.
Yeah.
Wizard words aren't going to save your grandmother from Alzheimer's, right?
Right.
It has to be a real technology, right?
Right.
Rather than just general advice. So
Yeah.
that's our task in the next year or two, and what we have now are these lab tests that we can do where we can see how many crystals are coming out of your head, and we can estimate in a very general way, how far along you are to getting Alzheimer's and how far along you are getting Parkinson's. And then this is the real breakthrough, which is you don't have to do a study based on somebody else's lab work. You do it on your own.
Okay.
Right? So if you come to see people like me,
Uh-huh.
now we can say, oh, look, your amyloid is much higher in your serum than 95% of the people at your age.
Okay.
Okay? Probably you're at a high risk for Alzheimer's.
A little bit of a concern.
Right?
Yeah.
I mean, probably.
Yeah.
You may not have cognitive impairment, remember? But that doesn't mean that you're not at risk.
Going to and
Right.
be at risk, yes.
And so, can you take medications that will lower your amyloid level so that you're at lower risk? Okay? We don't need to do a randomized trial.
You can do it.
We don't need to do it's not a
Retest
randomized
it?
trial because it's an N=1 trial,
Yeah.
right? It's
Well,
just that simple.
Medicine does that all the time, right?
Right, but there's no longer all this complicated bureaucracy
Mm-hmm.
and fundraising and IRBs and papers and consultations. The only conversation is between the doctor and the patient, is, hey, my amyloid is too high. I'm worried about it. What seems to be the data that might help me?
Right.
Well, the rubber hits the road.
Right.
In 3 months, if you've done something and your amyloid's still going higher, it's not working.
That didn't do it. Yeah.
Right? You give it up, right?
Right.
If 3 months later your amyloid's lower, probably you're moving in the right direction, right?
Does this blood test have a name? Like I've never heard of this before, or what?
It's new.
Okay.
It's called the ATN profile, and you can get it
yeah.
at LabCorp, but I think
ATN.
Quest has analogs, and I
Interesting.
called the lab director about 3 months ago,
Yeah.
and he says, hey, how did you hear about it?
Oh my gosh.
Right, which is
Cutting edge.
well, no, I mean, why wouldn't we hear about it?
Yeah.
Which
Yeah.
is, again, sort of odd.
Right. Why are we keeping it a secret? Why does not everybody?
Because there's
know
no
about
money to be made.
it? Right.
There's no money to be made, right? There's no FDA-approved treatment for Alzheimer's that is reasonably cost-effective. And, the standard story is people go to their neurologist and they get an MRI and they get neuropsychiatric testing and they say, oh, yeah, you probably got early mild cognitive impairment Alzheimer's, go home and die. That's what you hear,
Yeah.
right? It's hopeless,
Yes, it is.
right?
Yeah.
And I don't think that the animal data suggests that it's hopeless.
I love that.
And there's actually some human data as well on this issue about, reversing elevated tau and amyloid. But I'm only new to this area,
Yeah.
right? And I'm sure that if I would to listen to this podcast 2 or 3 years from now, I'd say, oh, geez, why did you say that?
Well,
Right?
it's
It's
where
just
we're at
new.
today.
It's where
and
we're
it's
at
new.
today, right?
Yeah, and that's okay.
Right.
I mean, that's
And
how we
so,
progress.
okay, so that's one development, which is
Yeah.
good. And I think the final development that comes out of this, which we're working on right now in my office, and we'll see if we can make
Yeah.
it work, is leveraging social media,
Uh,
right? In the old days, you had to count on your doctor or your healthcare provider's programs to hook you up with people that knew what they were doing.
right.
And that's really dangerous because these institutions, their incentive is to take care of the institution, not to take care of you. Right?
Okay.
I mean,
Yeah.
essentially, everyone at a large organization is employed by Medicare,
Oh,
right?
Right.
And their incentive structure is to not make Medicare mad. I mean, it's not a personal criticism.
Yeah.
It's just the way institutional incentives build up.
Right.
Right.
Yeah.
And we saw how that failed in the last 3 or 4 years, having large institutions look out for our medical interests. That didn't work. And so what needs to happen is to have people who have very similar patterns of aging connect with each other in the local community.
Yeah.
And you can use an artificial intelligence program to find people that seemingly are very different, but actually have exactly the same biochemical process. And then they connect with each other, and then they can do these experiments at much higher rates. Right. So it's one thing to have Turkey do an experiment, but what if we could use something like 23andMe kind of ideas?
Sure.
Where you get this kind of testing, and immediately you're hooked up with 50 people throughout the country who have almost exactly the same deck of card hand that you have.
Right. Yeah.
Right. And we can do this.
Right.
We know we can do it.
We know how to network the
I'm doing
people.
this now in my office.
Yeah. Wow.
Right. Where so you connect people
Yeah.
that have almost the same biochemistry, and then there's no longer guesswork.
Right.
Because if it works for you,
then
it's going to work
do
for
it
the person
here.
who has almost exactly the same biochemistry.
Right.
And so now you can do this incredibly rapid search.
And then it would become just tracking which go with what parameters and what were the outcomes to be able to cross that out.
Every experiment that everyone does
Yeah.
is providing a piece of information for everybody that's closely related to you.
Right.
Right? So you can bootstrap every drug trial
Yeah.
if you do the mathematics right. That's a task that's a little bit beyond me, but the math is pretty straightforward. This is the way to solve this. You know, to move away from this crazy idea that there's one disease, depression.
Right.
Or this crazy idea that there's one disease, Alzheimer's. Or this crazy idea that there's one disease, fibromyalgia.
Yeah.
These diseases are an imbalanced hand, but you still need to know, do I have the 2 of clubs or not?
Right.
Or do I still need to know, do I have the 5 of clubs or not?
You've got to get that background.
You've
info
got to
first.
get that granularity, and that's where having patients control their own data and having patients meet with people that have the exact same disease that they have is going to just, like, the innovation will be within a year,
That would
2.
be
I mean, you won't even be able to keep up with it.
Wow.
Right. And our healthcare system's just going to collapse because all of these concepts of, like, the FDA decides this is a good drug, and then you go to your insurance company who agrees whether or not it's a good drug.
Right.
Right. It won't make any sense anymore. It'll be nonsensical.
Yeah.
Once we get that kind of artificial intelligence computer technology up and running.
Well, and it's evolving so quickly that
Very fast.
Yeah.
Very fast.
every day.
So it's exciting, right? I mean,
Yeah.
I think we're going to cure Alzheimer's. I think we're going to cure Parkinson's. I think it's not going to be in 20 years. I think it'll be very fast. I'm hoping it'll be very fast.
Me too.
Yeah.
I don't want either of those. I work very hard to protect this noggin of mine.
Yeah.
Oh, that is wonderful. This
Yeah.
has been a lot of fun. If there was one last thing or one last tip or trick or takeaway point for our audience today, what would you want to leave them with today?
Don't trust your doctors,
Okay.
right? You know, we can only hold 7 items in our head at once, right? And 3 to 4 of them, of the items in our heads, are knowledge about you. You know, that's not related to your illness, but it's just related to being a good person and making you feel comfortable at home, and that you're respected and taken care of. I mean, this concept of a bedside manner is nothing more than being polite and a good person.
Yeah.
But it takes effort to be polite and be a good person, and then you're trying to think about a complicated illness at the same time. And guess what? We're not smart enough. It doesn't matter how much we study, and it doesn't matter how dedicated we are, and it doesn't matter. The the complexity of what we deal with every day is beyond our abilities. And so it's just very important to get second opinions.
Oh, yeah.
It's very important to try your best to read about what you think your illness is. You know, I think it's absolutely fantastic if you're blessed with a friend or a family member who's one of those genius people who just really is very sharp, right?
Yeah.
To bring them with you to your appointments.
Oh, right. To have that extra ears and note taker and advocate.
Absolutely. You know,
that's very true.
You can't trust the medical system. You can't.
Yeah.
Don't trust it. And you know, that's hard to tell sick people who are really worried that someone must take care of them.
Yeah.
Right? I mean, it goes against every instinct you have to just like relax knowing that someone's going to take care of you. But
right.
But a little bit of healthy skepticism is a really good thing.
Or at least ask those questions, right? Ask the question deeper and double check it.
You can't be shy.
Yeah.
It's your health. It's your health. It's your health. It's not my health. It's not my credentials. It's your health. I'm your employee. I work for you. That's the way it's got to be.
That's awesome. That's good advice. Very
Yeah.
good advice. Well, with that, I want to thank you so much, Dr. Berner. This has been a ton of fun. I knew it was going to be fun. It honestly was more fun than I even thought it was going to be fun. So cheers to that, right?
Okay, good.
And with that, thank you for sharing the information. Want to remind our listeners that the best way to go about becoming a new patient with you would be to email your office. And the email address is jonbernermd@gmail.com, and Jon, Jon, Berner, BERNER, MD@gmail.com. That's all together. And the website for your office is woodinvillepsychiatric.com. So I won't be surprised if you have a few of our listeners that maybe want to reach out or ask a question or something like that. So thank you for sharing that.
Happy to meet my neighbors in the area.
Yeah, absolutely, for sure. And that's all for today's episode. Thank you so much for listening. If you enjoyed what you heard, please subscribe to our channel and give this episode a like. Stay tuned for more insightful discussions on health and wellness. Until next time, take care.